I would rather tell a story, and I'm going to apologize in advance, and then this story is going to give me way too much credit, and it's also going to exaggerate a lot of things, but I think it helps with the points that I hope comes across. So the story begins about 5 years ago when Dr. Levy says to me, would you like to run a general hospital? And we were actually playing poker that evening when he mentioned it to me, and I kind of got what he was saying. I'd previously, or was running our psychiatric facility, and the person in my role had somewhat unexpectedly taken a job and was going to leave to Texas. And when Dr. Levy said it to me, the reason he chose me, and he said this, is we were just about to move into a new hospital, and we couldn't afford the time to go find somebody who really knew how to do the job. So if I could just fill in and execute the move, and then once the move happened, we'd do a national search and get a real CEO. So with that vote of confidence, I called my parents and had my dad FedEx me some new neckties because I didn't have a lot of ties at that time, and I got a few new suits. And on the first day on the job, somebody came up to me and said, how many bunkers should be in the MOB? And I didn't know what a bunker was or what an MOB was. So I felt like I was a little bit unqualified, and that the job police were going to come in and tell me, you really weren't supposed to get this job. I did get an email today that MOB got licensed today. It has 2 bunkers in it. I now know what those 2 things mean. And we'll start seeing patients in there in a few weeks. So with really a sense that I realized there's no way that I'm going to ever gain the expertise of the kinds of people we heard today. I could talk pretty deep if you wanted to about attention deficit disorder or autism, but that wasn't going to really help me run the UCLA health system. So I did what I felt most comfortable doing, and that was actually meeting with patients. So really for the first 3 months, for about 2 hours a day, I'd go knock on doors, and I'd sit down in patient rooms and say, hi, I'm Dr. Feinberg. How's the care? And every patient that I saw got my business card, and every patient that got my business card, I'd write down my cell phone. And I'd give them a message of, call me 24 hours a day if you need anything. And during those 3 months, I helped patients to the commode. I put stockings on patients. I ran down to the pharmacy and got meds. I cried with families. And really what came clear to me were 2 things at the end of those first 100 days. And one was that UCLA performs miracles that I'd really not been accustomed to, having been holed up in our psychiatric hospital prior to my release into the medical center. And those miracles were around transplants and biopsies and really figuring out things that other places couldn't. And then the other thing that I learned is that we never served hot food that was hot, the cold food was never cold, the place was dirty, no one knew who was in charge of their care. 2 out of 3 patients would not refer us to a friend after discharge. It was pretty clear if you lived in Southern California and you got sick, you went to Cedars or St. John's. If you were dying or needed a particular knuckle transplanted to another knuckle, we might have that guy. And you came to us, and I'm not sure what our mission statement or our purpose was 4 or 5 years ago, but it should have been something like, we're UCLA, and you're lucky to see us. And that was not completely consistent, because there were definitely pockets of excellence. But it was typical. It was typical that we would basically say, wait in line and we'll take care of you when we can. Now, I'd come from the psychiatric hospital, which was connected through the Center for Health Sciences. This is before our move. And it was a bad, ugly building too. It had elevators, it actually still does, that don't stop at the right floor. The bathrooms were down the hall. We had residents. We had all those excuses. But we took 40% of our patients involuntarily. They were suicidal or homicidal. We'd literally shoot them up with meds, strap them down with leather. By definition, they were crazy. And we'd bring them upstairs. And we don't do much in psychiatry, right? We have a few pills. We talk to people. And once in a while, we shock you. And those patients, 90% of them, would refer us to a friend at discharge. And I thought, wow, if we can do it with crazy people that don't even want to come in, how come that 16-year-old girl that just got a liver transplant, where we saved her life and she's going back to play soccer in Santa Barbara, isn't going to tell her friends about us now in the med center. So I went to groups like this and I said, with much less confidence than I have now, I think we need to be more focused on the patient. I didn't even know what HCAHPS were. I didn't know a lot of words. I didn't know throughput, all kinds of stuff, but I knew we weren't compassionate. And so I'd speak to groups like this, including our chairs. And I got to be careful because some of my chairs are here right now. But picture this, it's probably not much different at the other UC campuses. The room is filled with 13 people. 12 of them are men, and almost all of them are bald. And I say to these people, all white, and I say to these people, we're going to focus on the patient. And about a third of them look at me like we're crazy, we should have never hired the psychiatrist, we've done customer service before, I got a mug, this doesn't make sense. A third of them were kind of on the fence, and now I'm talking about the whole institution. And then some would come up to me after we talked and say, you're so inspiring. And I'd go home and say to my wife, inspiring? I'm talking about making sure we have enough bedpans at UCLA, because I met a patient today that didn't have a bedpan. And when I come back to my team and say, we're short of bedpans, you literally heard things like, well, we got trouble with central supply. It was just excuses. Actually, we had no money too at that time. So I learned about HCAHPS, and I learned that we were in the 38th percentile on those two most important questions to me. Would you refer us to a friend and rate us on a scale of 1 to 10? And our ER was in the 14th percentile, and one of our ERs was in the 25th percentile. 6,000 hospitals in the country, you'd have to go pretty far to find one that was performing worse than our emergency room. And actually, that's where the changes began in the beginning. So we made this, and I had an incredible team, still have an incredible team, and we made these changes literally one patient at a time. So if we saw a patient that needed something, we took care of it immediately. If we saw a patient that needed something that needed a systemic fix, we did our best to make that systemic fix happen immediately. We went from 38th percentile to 99th percentile. We're the #1 rated academic medical center. Don't clap. No, this is not the clap part. We're the #1 rated academic medical center in the country on those two questions. 99th percentile is terrible. To be 99th percentile on those questions, you have to have 86 out of 100 people check the box off number 9 or number 10, or check the box that says always. That means 14 patients that we've seen at UCLA, 14 out of the last 100, don't think that we're spectacular. They came to us in their most vulnerable time. We get patients by helicopter. We see 1.5 million patients in our outpatient setting. We do more organ transplants than any hospital in the United States, just did a hand transplant. But 14 out of 100 patients still do not think that we're doing a good job. So in my opinion, I think UCLA is one of the best in a very, very bad industry. I don't think we can stop until it's 100 out of 100 patients. So now you can clap. Okay, that's better. We've changed our purpose statement to healing humankind one patient at a time by alleviating suffering, promoting health, and delivering acts of kindness. So let me tell you 2 stories where one I think we didn't make it, and one where I think we did make it. And we're going to do our best to get as many of those cases to the did make it. So a 63-year-old woman comes into our ER with abdominal pain. And we do some scans on her. Now I think we have to check on the amount of radiation we gave her, but we'll follow up on that. We do some scans on her, and we say, you need your gallbladder out. So we send her husband home and tell him to come back in the morning when she's going to be ready for surgery so he could go get some of her personal belongings. Well, we reread the scan, and we find out actually it's fine. She doesn't need her gallbladder out. She can go home. So it's 2 or 3 in the morning, and we tell this 63-year-old UCLA alumni, you can go home now. We misread the scan. Well, she doesn't have her coat or her purse because her husband took it. So she asks our nurse in the ED for a taxi voucher. And our nurse says, no, you don't qualify for a taxi voucher. You make too much money. So she scrounges around in her sweater that she has and has enough money to go part way home. And then the husband comes, picks her up in the middle of the night as far as the taxi could take her. And then we call her and say, no, we've reread the scan. You do need your gallbladder out. So come back in. Oh, it gets worse. So she comes back in. We take out her gallbladder successfully. And in the OR, the anesthesiologist comes up to her and asks her to sign a consent for HIV testing because we reused a syringe on her that we'd used on a patient before. So if you really think about it, it was a success. A patient had a gallbladder that needed to be removed, and we successfully removed it. So if it were my mom, I would consider that, though, a disaster. What an experience over 24 hours that we provided to this patient. So what do we do now to use that story to change? We literally bring everyone in that's involved in her care. Immediately, that story changes our taxi voucher policy, our syringe policy. It really gets people, I think, in an organization to move to where we want to be as far as caring for those as if they were part of our family. So here's a better one. There's this nurse who works for LA County as a quality assurance nurse. She's hiking with her family in Nevada, and her family is beautiful, the nurse is beautiful. They look like the picture you get when you buy the frame with the family in the picture. She's married to the fireman, 2 gorgeous kids, they're hiking, they're very athletic. She gets some cardiovascular problem, some hospital in Henderson tries to kill her. She's airlifted to UCLA. She needs to get a transplant. We put some device in that's going to be a bridge to transplant. She's in a coma. Everyone does everything they're supposed to do in the ICU. She's the first case that we've ever had that actually recovers and doesn't need the transplant. We take the device out of her. It's great, right? Regular UCLA save a life. And then we talk to her about her care, and we talk to her husband. So after being in a coma for about 3 months and finally waking up, 3 weeks, and finally waking up, she was ready to have a bath. And so they get her in a chair, our team, and the care partner comes over with a bucket of hot water and walks away. And the nurse is thinking, well, I know how to do a sponge bath, and that water's going to get cold. The UCLA nurse doesn't know what she's doing. This is what she's thinking. But the care partner comes back with a second bucket, and then the patient thinks, oh my God, I must be really dirty if they need 2 buckets. But she leaves again and comes back with a third bucket. And in the third bucket, she uses to give her the bath, and she puts her feet in the first 2 buckets to keep her feet warm during the bath. When the bath is over, she gives her a massage of her feet and puts lotion on her feet. Well, this nurse goes on and on about those types of interactions at UCLA that completely blew her away. About her husband saying to us, he finally left the hospital after 9 days because they said she was stable enough that he could go home and get a shower. He's not 10 minutes out of the hospital and his cell phone rings that she's in VTAC. He says, I'm literally on the edge. I haven't slept in 10 days. I got a stack of cards from UCLA people with their business cards and their cell phones on it. And he flips through them and he finds the guy who he thought was in charge. And he did pick the right guy. It was our cardiovascular surgeon. And he calls the surgeon on his cell phone, and the surgeon says, I'm in New York City at a meeting right now. Give me 1 minute. He was actually at a dinner. Let me walk outside and talk with you. And the husband talks about our doc answering his cell phone and talking to him for 45 minutes from New York, interrupting his dinner to get him off the ledge and tell him it was going to be okay. That's the stuff she remembers. That's the stuff he remembers. That's the kind of care that I'd want for my mom or dad or my brother or sister. And so that's our standard. We've done a lot of things to get from where we were to where we are now. We got a long way to go, but let me just go through a list of some of the things that we've done. We hire people differently. We use a program called Talent Plus. It was developed by Ritz-Carlton. It looks for service-minded individuals. So if we need a nurse in the PICU, not only do you have to be not a felon, have good resume from Kaiser. We liked you on your job interview where we would hire people before. Now we actually do this Talent Plus interview and found that about 50% of the people that we would have hired that our HR people liked are not right for the UCLA health system. It's been dramatic to kind of watch as those people come in to see how they perform, decrease turnover, and how that's helped change the culture. With really incredible direction through our chief nursing officer, we took all our nurses offline and did a 3-day program at different times around relationship-based care. So they really got nurses back to why they want to be nurses. We have rounding handoffs at the bedside for the nurses, sign-outs at the bedside, interdisciplinary rounds where every patient, every day, everyone involved in that case discusses it. Before we did that, 25% of the time, the nurse taking care of the patient learned about that patient's discharge. That nurse's patient learned about the discharge 25% of the time from the patient. So we get people together, talk about what's going on, every case, every day. On all of our units, we have huddles, we discuss what's going on, we celebrate the successes. We're really holding people accountable. We have a program called CI Care. It's just an acronym for how you go in the room, introduce yourself to somebody, ask permission before you touch them, answer questions, how you exit. When I started this job 4 or 5 years ago, I would get letters and emails that were all the same. People were upset about their bill, they were upset about the care at UCLA, and they wanted a pound of flesh. My mail and email, and this is pretty anecdotal, has changed dramatically. And every letter now reads pretty much the same. They talk about how they were greeted by the valet parker. They talk about how our admission staff was so helpful. They talk about how amazed they were that somebody walked them to their location, that they weren't lost, how everybody introduced themselves. They talk about our transport team. They talk about our lift team. They talk about our doctors and our nurses, our social workers and our pharmacists. We had a patient that died, and we said to the family, you can go down to the morgue to visit. And the family said, we're uncomfortable going down if we can't go down with the gentleman who's part of your lift team. The lift team is the guys who help move the patients that we pay, I think, $12 an hour. It was his day off. We called him. He came in and accompanied family to the morgue. It's clearly a team sport. To me, as I listen to all these presentations today, I think it's absolutely imperative that we realize why we're doing this. I met with our management team about earlier this week on Tuesday morning, and I said, tell me what these 3 cases have in common. One is a 16-year-old girl, local, who has a thyroid nodule that needs to be removed. Another is a gentleman who's 48 years old from out of town who needs a heart valve replaced. And the other is a 68-year-old man who has liver cancer that's spread. What do those patients have in common? The common thread were all of their families were in our surgical waiting room that morning, this past Tuesday morning. Those people really don't care that we're UC. They don't care at UCLA that we have Nobel Prize winners. They don't care that we have a $1 billion building. They don't care that we're ranked number 5 in U.S. News and World Report. They don't care that we invented Herceptin. Really, all they care about is the people around them, the people with the badges. Are they going to connect with them in a way that they understand? Are they going to treat them with dignity? Are they going to treat them with respect? Is it going to be culturally appropriate? Are they going to partner with them in their care? And my sense is that's what we have this incredible opportunity to do. Oftentimes when I give talks like this, people say, what about the docs? Our docs are fantastic. All of them participate in the CI Care training program. It's part of their medical staff privileging. We have department chairs who are obsessing now on their patient satisfaction scores. Our residents all have baseball playing cards that have a picture of them, residents, fellows, attendings, and on the flip side, it explains what they do. Our neurosurgery department has gone months where they get 100% on did you know who your doctor was. Incredible changes from where we were a few years ago, but I think we got such a long way to go. So Jack, we even actually save money if we get out of here by 4. So I just want to thank you, and I'm happy to take some questions. Thanks.
That was really inspiring. I wonder, you're an extraordinarily good storyteller, and I'm guessing you use stories around your organization a lot to make these cases. We all are in amazingly large organizations where I think people's email capacity has been saturated. How operationally and practically do you disseminate these stories, both in terms of people's bandwidth to hear them and absorb them, and in terms of any story that you tell is going to get out to the community, to the media, and that has some challenges as well?
We definitely had our media challenges. So we use telling stories as an important part. When I started, if you went into our management meetings, it was almost hard to tell that we were a health system. It could have been that we were Costco, because it was just spreadsheets and numbers and occupancy and FTE and FTE or AOB, and there was no story about what we're doing. All our management meetings start with a patient story, but I would actually prefer a patient. So we have patients come and talk to our management team all the time. We have a thing that we call PCAT rounds, where our managers 3 times a month, twice in the day and once in the night, throughout our system, get together and then spread out throughout the organization and meet with patients, not in their own departments, in a structured way around patient satisfaction. And everybody gets back together and shares the stories, the wins, the losses, and all of that stuff, and tries to make changes right then. So we use the stories, I think, from a human standpoint, is a very easy way to learn lessons and to give our narrative. We use a lot of storytelling. The negative ones, the woman with the gallbladder has become a big fan of ours. So she knows we share her story. She appreciates it, and the same with the ones that are proud. So I think you're right that the stories can be a powerful motivator.
I'm Wendy Jamison with the California Healthcare Safety Net Institute. We work with all the public hospitals in California on a number of quality improvement initiatives, including patient experience. First, I just want to invite you to come to some Safety Net Institute event in the future, because I think all the public hospitals, including the county hospitals, could really benefit from your perspective. My question is, given the connection between, somebody said earlier today, it's, healthcare is people taking care of people. Given the connection between the staff and clinician experience, satisfaction, wellness, and patient experience, I wonder if you could share a couple things you're doing to improve staff and clinician experience.
There's a friend of mine, he runs the Burrell Institute, which is a call center, and it's one of the happiest places on earth, and people are the most important asset, and people. And I'm very explicit. People are not our most important asset in the UCLA health system. It's not our people, it's our patients. And the more that we have focused on patients, our staff engagement scores have gone up incredibly high. And I believe that 99% of the people that go into healthcare for the right reason, and if you make their work such that they can do their work and connect with patients, they're going to end up being happier. But we focus on patients, we don't focus on staff, and I'm saying that kind of an exaggerated way. And our staff has responded incredibly well to that. The other thing we do is, our chief financial officer, chief legal officer, chief of human resources, they all make patient rounds. They see patients, they give their cell phone. We give a little medical instruction to the non-clinical people about how to go in. We say if they're banging on someone's chest or there's tubes flying all over the place, just go to another room. But other than that, they're invited into any room. So we have our non-clinical staff make rounds with patients. It's actually, smiling is now in our job description. Everybody is required to go in and meet with patients.
This is Jeff Belcora again from UCSF. Thanks for the very inspiring remarks. And I'd like to counter with a story and get your reaction to it. I got a call from a CEO a couple years ago of a high-tech company whose personal assistant, executive assistant, had a cyst on her ovary. So she had seen a surgeon who was saying, well, we just need to take this out, take the ovaries out. and maybe go further than that as well. And the CEO was saying, you do this kind of stuff, you're a patient advocate, you know, what should happen? And I said, well, go get a second opinion. So the story doesn't involve any UC, but this patient goes and gets a second opinion at an academic medical center where they say, well, you know, watchful waiting is more indicated. But the patient goes back to the original surgeon who convinces the patient to have not only the ovary removed, but some, I can't remember the details, but a fair amount of debulking. And when they remove all these organs, they find no cancer. So the patient's reaction is total gratitude towards the patient for being so vigilant and for being so committed to early detection. And there was a kind of a cognitive dissonance around, partly because the service had been so wonderful. So the reason I'm telling this story is because my concern about academic medical centers in a lot of cases is the potential for overtreatment, the fee-for-service incentives that lead us to do perhaps sometimes more than is necessary. So I'm kind of wondering, you know, where does that show up on your radar screen? Because it's possible to deliver outstanding service and be doing the wrong things. Do you encounter that? Is that a concern for you, or how do you deal with that?
You know, I totally understand your question. And there's even some reports have come out now that outcome is worse in places that have high patient satisfaction. The study was looking at outpatient doctors, and it was doctor satisfaction, and you could over-test, right, and that can lead to satisfaction. I think we have our head in the sands. I'm a patient. You're a patient. I think patients are very, very smart, and in every other industry, they've figured out what's good care and what's bad care. And there's also excuses that academic medical centers and length of stay and age caps isn't a good thing. You know what? In any business, it's, did we take good care of you, or were you happy with the service? And I'm not an auto mechanic, but I know what happens if it was good. You know, I might have got ripped off, might not. I really believe in people, and I believe in patients, and I think they can make great decisions. Of course, we could talk, well, we have talked about changing from a volume-based system to a value-based system, et cetera. Are there incentives that are perverse? Yes, yes, yes. I still think people know what's good care. And they know if they've been explained something in a way that they understand. They know if they've been listened to. And when you really think about it, maybe that was the right care for that patient. Maybe that patient is such an anxious person that watchful waiting is something they could not tolerate, and maybe I could have. I mean, it's a very individual experience, and I think it's one patient at a time.
Thank you.
Thank you very much.